Thanks for being here. My name's Sally Dixon, and I'm a registered nurse, and I coordinate maternal infant health initiatives at the St. Joseph County Department of Health, which includes the fetal infant mortality review. And so we are so happy that you joined us tonight for the maternal mental health presentation. We talked about it, the speakers, and we want you to feel free to walk past us if you want a drink or coffee. You might want coffee. The longer you're here, it's a little chilly. Or need to use the restroom. We will not be offended by that in any way. So I'm going to do a little more housekeeping kind of things. And if you haven't found the restrooms yet, they're also that way. And then share a little bit of data with you. So, but before that, I want to thank all the people who contributed to making this event possible. So Beacon Community Impact through a safety pin grant from the Indiana Department of Health. And we've worked with Beacon Community Impact last year on our Achieving Birth Equity Conference, and so this year we're doing this maternal mental health event. The Eck Institute for Global Health, who is so supportive of our efforts with maternal infant health at the health department. Notre Dame Athletics is responsible for letting us use this wonderful space this evening, which I'm told you have to be a season ticket holder to be here, so this is very special. And then University of Notre Dame Research, and then the health department. So we should thank everyone. Because this is a CME event and Beacon is also providing that opportunity tonight, just a couple quick things about that. The accreditation statement, that Beacon Health System is accredited by the Indiana State Medical Association. They designate this a live activity for a maximum of 1 CME, so physicians, you know how to do that, how to claim that. I'll talk about that in a minute. Disclosure, we don't have any, the speakers don't have any potential conflicts of interest, and then no commercial support was used in planning the event. We are recording tonight, so that if the people who couldn't be here, will hopefully be able to share this with them later in some different ways. So in your folder, if you have probably looked in there already, everyone should do the evaluation even if you're not eligible for a CME. And so you can scan the little card that's in there, or you can scan the little table tent, or if you're like me, you can use the paper copy. I would prefer that. That's in your folder. So please do that so we get the evaluations. That's important. And then we will get the certificates to you later. And what's the other thing? Oh, also because included on the evaluation is a place to put contact information, because some of the things we talk about tonight, you might want a follow-up for your practice about where to get resources and things like that. So we'd be happy to follow up with you. But a little background on why we're here tonight. So the Fetal Infant Mortality Review Program, if you're not familiar with it, has been operating here in the county for 7 years. And it's a cycle of improvement process. We gather data from all the fetal and infant losses that happen in our county. We review those medical records, and it's a multidisciplinary team. There's probably quite a few femur team members here tonight, if you want to just raise your hand and wave. So it's a good group. And so we review those cases and go through a process of identifying opportunity for prevention of fetal and infant loss, looking at patterns and how we could make a difference, take community action, and improve outcomes. And so why we're here tonight is I think it's almost exactly a year ago, in spring of 2022, we noticed an increase in the presence of untreated maternal mental health factors in infant and fetal deaths. And so we recommended creating an educational event about the topic to improve outcomes. So I just have a couple quick slides just to show you, get an idea about the fetal infant mortality review. So this one shows the percentage of mothers with mental health diagnosis in reviewed cases of fetal infant loss in St. Joseph County from 2017 to 2021. And the lighter blue is fetal loss, and the darker blue is infant loss. And so you can see that the percentage of mothers who had a loss with a documented mental health diagnosis has been pretty consistently high. There's been a couple times it's a little bit lower. I think our record access has been better, which might account for it showing up a little higher. But certainly in 2021, in the spring when we were finishing up that year's worth of cases, we saw an increase. And in 2022, we're seeing the same thing. And then this one shows you, if you combine the fetal and infant deaths together and then disaggregate it by race and ethnicity, for Hispanic mothers, any race, we don't have that many numbers, so that isn't as a meaningful number. But for everyone else, you can see it runs around 40 to 43%. So it's pretty significant. And we know that that can contribute to losses. And then just to tell you a little bit about substance use and the connection with maternal mental health. So of the mothers who had a fetal or infant loss who used one or more substance during pregnancy, it was about 31%. That's all mothers. And then 54% of the mothers who used one or more substances had a documented history of current mental health diagnosis. And sometimes when we're reviewing cases, even though there's not a documented history, there's certainly evidence of it. And so for those mothers who did use one or more substances and had a mental health diagnosis, 26.3% used tobacco only, 21% used a combination of tobacco and THC, and 34.3% used THC only. And this includes mothers who maybe used tobacco or THC and stopped once they became pregnant. I think the one thing that's interesting with fetal and infant loss compared to maternal mortality is that opioid use doesn't show up much in the fetal and infant losses. In moms who had a maternal mental health diagnosis, it's less than 5 mothers. So, but when Dr. Arnaudo shares, it's certainly different for mothers for maternal mortality. So following that recommendation, our case review team has work groups, and so our maternal infant health work group kind of received that recommendation and started working on topics and methods for organizing this event. And so that's how we're here tonight during Maternal Mental Health Week. So it's amazing that it can take a year to put something like this together. So I am going to introduce our speaker. Camila Arnaudo is an addiction psychiatrist based in Bloomington for 14 years. She completed medical school at the University of Maryland School of Medicine in Baltimore and completed her residency in psychiatry at Harvard Longwood Psychiatry Training Program in Boston, Massachusetts. She completed a fellowship in addiction psychiatry at Indiana University School of Medicine in Indianapolis. Her current work focuses on mental health and addictive illnesses in pregnancy and postpartum people, with particular focus on increasing equity and accessibility to quality care. In her role as adjunct faculty at the Bloomington Regional Campus of IU School of Medicine, she teaches first-year students about clinical aspects of medicine, especially how to interview patients, and teaches third-year students the basics of psychiatry. She's the medical director of Addictions Treatment and Recovery Center at IU Health. She's a member of the Indiana Maternal Mortality Review Committee and co-medical director of Indiana CHAMP program, which we'll hear more about tonight. So please join me in welcoming Dr. Arnaudo.
Thank you so much. Thank you. Can I use this? I move around a lot, so I'm gonna try to switch to this one.
Yeah. Is that good? Oh yeah, that works. Okay, so I'll advance into my slides. So, as Sally said, Lisa and Sally are going to confuse me right here together. But as Sally said, I'm going to be talking a bit about perinatal mood and anxiety disorders. I will touch a little bit on maternal mortality data, just a little bit. Tomorrow I'm speaking at the other event, and I'll talk a lot more about it tomorrow. The focus of this talk is to really talk in practical terms. There's just not enough psychiatrists, as we know, in Indiana, obviously, and I trained in Boston, and even in Boston there aren't enough psychiatrists, and relative to the rest of the United States, they're overflowing there. And the reality for most patients is that they would rather, see their providers anyways. So the idea of this talk is to empower non-psychiatrists to be able to take care of the perinatal mood and anxiety disorders in their own clinics with some support from CHAMP and other services that I'm going to talk about today. So first off, what are these disorders, these PMADs that we talk about, these perinatal mood and anxiety disorders? In the old days, you might have called it, postpartum depression, postpartum anxiety. You can still use those terms, they're completely valid. But we want to emphasize the fact that these disorders don't just occur after, but throughout the pregnancy and postpartum period. So PMADs is a big term. It includes a lot of diagnoses, and we'll break it down as we go along. So these disorders are very prevalent, first of all. They are the number one complication of pregnancy is to have one of these diagnoses. And the combination of mental health and substance use disorder is the leading cause of pregnancy-associated deaths in the United States and also in Indiana. In particular, the late postpartum period has been identified as the highest risk period. And at that point, many people are not really engaged with their OB care anymore. Most of them are actually not engaged in any kind of mental health or health kind of treatment. But the idea is that they could be, and this is, in my opinion, where non-psychiatrists, but also non-OBGYNs can have an opportunity, to step in and help. So this is another slide from Kathy Wiesner's paper from 2013. Whenever you hear numbers about how many people have depression, a lot of it comes from this paper. And they found that the rates of unipolar depression, so that's major depression, basically the main diagnosis, are close to 70%, and bipolar is around 22.6%. And the unipolar depression tends to have a lot of anxiety associated with it. And most of these diagnoses are, coming to light in the postpartum period, but they also are occurring, during and before pregnancy. And quite alarmingly, up to close to 20% of these individuals have suicidal ideation or thoughts of self-harm. I think this is way underdiagnosed and underappreciated. So in terms of the Indiana Maternal Mortality Review Committee, this is the report that we put out in 2022. And I'm highlighting here that there's different kinds of pregnancy associated or related deaths. Most of you if you thought about maternal mortality, the deaths that you're probably kind of thinking about are things like, hemorrhages or complications of birth, things like that. Those would be pregnancy-related deaths, and they're by far a minority of the deaths that we see. So it's only out of the, total cases, only 18 of the cases were pregnancy-related. They're in the middle column here. The majority of cases are actually pregnancy-associated, all the way to the left, and those are the ones that tend to be related to mental health and substance use disorder. So that's the chart here. On the left, you can see that it's 117 deaths in 2020 versus per 100,000 live births, whereas for the related deaths, it's only 22 per 100,000 live births. And the reasons that they use this number, 100,000 live births, is to give. Otherwise, it's just a number. It doesn't allow you to consider how many people were born at that time. It's also really important when we're looking at data related to racial disparities, because if you just look at absolute numbers, if there's less people of that race, then it doesn't look as significant as it really is. So here are, for Indiana, between 2018 and 2020, and that N of 18, that's a mistake, right? That's the related deaths, so that is just a mistake in the report. I didn't fix it because I took this from the report. But if you see here, overdose, which can be either accidental or of undeterminate intent, was by far the most likely reason that people died in pregnancy-associated reasons. Also, suicide, you can see here, is quite high. Again, if you think about this, COVID-19 was going on during this time, and there were 3 COVID-19 deaths at the very bottom over here. Whereas for suicide and accidental overdoses, there were 12 suicides. And there are possibly more suicides because when we review these cases, we cannot call it a suicide unless we have a note or substantial proof. Sometimes it's very hard to determine if it was accidental or a suicide. And then homicide is one of the other leading causes. And for many of the people that died in homicides type situations, many were related to IPV. So where they knew, the attacker, but not always. And also for many of these individuals where homicide was a problem, they had either mental health history or other involvement with like DCS or other agencies that indicated that there was trauma or potentially mental health trouble in their life. Not to say it caused their homicide, but they were just disadvantaged or in some way not receiving all the services that they could. Oops, I don't know what that is. Let me close that. We're not going to print right now. Okay. But probably most of us here who, if you've worked on femur or you probably realize or have heard that the majority of deaths, or a disproportionate number of deaths, I should say, are occurring in the non-white population. That is definitely true relating to mental health. When it comes to addictions, it's a little bit more mixed, but it is also a leading cause. It is a very relevant cause of death in that population. And then here's just to point out what I said previously, that the late postpartum period is a time of particular risk. And what is happening, in the postpartum period? Why are people disengaging from care? Well, one concept that's really important is the fourth trimester. It's a more recent, it's not so super recent, but it's not an old concept. The idea being that there's a lot of changes that are happening for people in the 12 weeks, after birth. This is also a time when prenatal care has ended, and individuals are kind of on their own. If you have a mental health diagnosis or an addiction, it's possible your child has been removed from your care. If they are in your care, there's a lot of sort of like disappointment that is happening because these little babies did not solve every problem you thought they were going to. They're also not really like a cute little Gerber baby. They're probably little and wrinkled and cry a lot and keep you up at night. And if you have been a victim of trauma or poor self-care, or not well taken care of as a baby, a lot of times it's quite triggering to now be in charge of another life. And it's not at all what you expected. Not to mention that a lot of our people that we're taking care of, have to go back to work. They have financial stressors. They have other children that they're in charge of. They may be taking care of elderly parents. So it's not really a very rosy time. How could a primary care provider or a non-psychiatrist intervene in these times? Well, for different times, I'm going to kind of focus on the postpartum period. This slide includes other timing as well. But it being a time when potentially a primary care patient, doctor who's aware that their patient is no longer pregnant, no longer in OB care, could step in, intervene, and begin to play some of this role. Because one of the big barriers to treatment in this period is lack of training, but also lack of detection, and also we don't want to detain people, and lack of integrated care. So maybe screening is happening in one location, but they're not communicating. For example, in Bloomington, where I am, the peds screens all the moms, that come in to bring their babies in, but they don't always communicate back to the OB or be able to communicate back to primary care what's happening. So it's an opportunity. That's kind of like an unmet opportunity. Just to say, this is a slide. Some of these slides that I'm showing are from PAP for Moms, so I wanted just to acknowledge them and their wonderful website that you can go on. They are another perinatal access program like CHAMP, so I'll mention them again, but I wanted to put this in here to acknowledge that I'm using a lot of their slides because they're quite excellent. Okay, so we're going to go back to the barrier, which is lack of detection, right? So this is from a project, a really excellent project, and I'm going to read this to you just because I'm not sure. Well, you might be able to read it, but I'll go ahead and read it because it's pretty powerful. So when this picture was taken, I was suffering from severe postpartum depression. You can't tell by looking, but just hours before this picture was taken, I tried to kill myself. I had been sobbing for 2 weeks. An hour after this picture was taken, I got up on stage and performed for a church talent show, like everything was fine. So this is this woman, Adrienne Feldman. This is her story. If you go on this website that's listed here, there's her story, but there's many other women took their pictures and had similar stories of situations where
they were quite depressed, had suicidal thoughts, but they just didn't tell anybody because of stigma and very many other reasons why people don't feel comfortable sharing. And so we have to use other tools. One of those tools is Edinburgh Postnatal Scale. And because I know some of these slides don't show up perfectly, and because I wanted you guys to have somewhere to take some notes, it is in your folder that you received are all the screening tools. So feel free to flip to that right now and take some notes on this. So this is, I think, already used in this community from what I hear quite readily. And so I won't belabor what it is, but I will say that it is a quite excellent tool, that the way the questions are asked are very non-confrontational and, readable and relatable for people. And I also want to point out that questions 3 to 5 are an anxiety subscale. So I think what makes the EPDS pretty special compared to PHQ-9 or other screeners is that it lets you hit 2 different things, because many patients come in and they don't think they have depression. They don't feel depressed or feel sad. What they feel is worried and anxious. Sometimes worry and anxiety are part of depression, but sometimes they're a separate thing. And so this subscale is quite nice. So if your patient is filling this out in the waiting room, which is where I think a lot of people do it, or they have the nurse, make sure you look at the actual form to see what they're scoring on, because it will give you a really good hint. And you can ask them follow-up questions about it. Like, tell me more about feeling panicky, for no good reason. Like these are such relatable questions, compared to some other screeners. So the patient screens positive on EPDS. Now what? This is a big reason why people either don't use a screener because they don't know what to do, or they use it, but they don't do anything with it. So they have a score, they maybe write it down in their note, but they don't know what the next thing should be. Well, my Pat for Moms has some great slides about this, and I'm using them today. But let's see, the first thing is you have to assess the severity and comorbidities, but also really you have to try to get a diagnosis, right? Because the EPDS doesn't give you a diagnosis. It doesn't say this person has major depressive disorder, or this person has, GAD, generalized anxiety disorder. Before you have a diagnosis, you can't really treat the person because some forms, as we'll hear more, but some forms of depression, you wouldn't want to give someone an antidepressant because you might make the situation much worse. So after they screen positive, the next thing you have to do is try to get a diagnosis. For example, for major depressive disorder with postpartum onset, there is another screener you can use. You can use the PHQ-9, which I was just maligning a moment ago, but it's not good as maybe like an initial screen for people with P9s, but once you have that they're positive on EPDS, this is very helpful because these are the criteria that is in the DSM-5, which is like the psychiatry handbook for diagnosing. So then once you've used the EPDS, they screen positive, it's mostly not the 3 to 5 block. You can use this to figure out if they have major depressive disorder, or at least to gauge the degree of it that they might have. Very, very helpful. Another one that's pretty easy to use, patients can do it. I do find that when I do the screen with people, because I actually ask them these questions because I want to kind of see how they answer it, they will cry sometimes while answering these questions. So you probably want to prepare them a little bit, that it might feel hard to hear what it says on here. Because some of these things are this is one that people usually cry on, is feeling bad about myself, or that I'm a failure or have let yourself or your family down. So that's one that when you bring that one up, a lot of people cry about that one. Number 8, moving or speaking slowly. That's about psychomotor agitation or psychomotor retardation, and people don't usually have that. You have to be very, very depressed to have that one. So I'll say the next one's not very common, because otherwise they say, what are you talking about right now? But the one about feeling bad about yourself makes people feel pretty sad when you say that. And then of course there's a question about hurting yourself, and you want to ask that carefully. And then it also asks at the very end, how difficult are these symptoms for you? And you really want to assess that, because if maybe their score isn't very high, but it's very difficult for them, and that's very meaningful as to what you want to do next. What about if you don't think it's major depression, maybe it's generalized anxiety disorder? There's also a screener This also follows some of the criteria that are in the generalized anxiety disorder criteria. If you're using all these tools and then you're gonna actually do something with them, you're not just doing it and then putting it in your chart, never looking at it, you can actually use billing codes for this. And I don't know all the codes, I'll be honest, I'm not a billing person, but I know for people who are spending time on this out of their schedule, that is an important thing to know. The other thing about all three of these that we've talked about so far is that there is research actually. It was a researcher, she used to be in Bloomington, did some of this stuff, she's in California now. But there are studies that show that using these screeners, so if you're gonna prescribe to someone, doing this sequentially when they come in and having a score and using that to, and not the only thing, but in part to judge what you do next, has a benefit for their in terms of, like, it shows more people who are screened regularly when they come in for medications have faster improvement in their care. And I don't think they know exactly what. I don't know if it's that the doctors are changing their medicine more, or if there's something about using a rating scale that is impactful that way. But utilizing scales, not just how are you feeling, promotes a faster improvement in their symptoms. So integrating this into your practice, not just using it to figure out if they have it or not, but to track how symptoms are evolving based on what you're doing for your treatment seems to be meaningful. So you've done this first part, you've figured out, let's say in their case of your patient, they have major depressive disorder. You want to use the PHQ-9 to figure out, or another tool to figure out how severe is it. And then, the kinds of things that might point to more severity would be things like suicidal ideation, difficulty functioning, psychotic symptoms, of course, very serious, or comorbid anxiety. And then you also, since we already said there's going to be times that they're going to have thoughts of suicide that are going to be picked up by those screeners or by you just asking the question, you want to ask some additional questions about, have you ever attempted to hurt yourself? Have you thought about ways that you might do it? And then you want to review what are some suicide risk factors. And of course, if you identify, yes, all these questions are suicide risk factors, you would do whatever the emergency protocol is for your clinic to get additional help. Perhaps you have access to a social worker that can do a risk assessment. Perhaps you have to use your emergency room or something like that, but you certainly want to act on it, obviously, because it doesn't help to know about it if we don't do anything about it. The other very important thing is that you want to rule out bipolar disorder before you were to prescribe antidepressants to anybody. And I'm sure this isn't going to surprise you, but there's a screener for this as well, which we'll talk about in a minute. But before you get to that screener, because I find that screener a little weird in my opinion, it's helpful, it's definitely validated. Kathy Wiesner will tell you it's validated, it's a good screener, but it is a little weird. And if you don't ask some basic questions or have some basic, common sense, you can end up having people screening positive on that do not have bipolar, and it can send you down a crazy chase. So how I ask this question is, have you ever gone more than 2 days without needing to sleep, without using drugs or other means to stay awake? And if the person says yes, that still doesn't mean 100% sure they have bipolar by any means. But you can ask additional questions like, how did you feel during that time? And then people might say, I felt great. I just got so much done. I was running around. I made so many plans. Actually, someone just told me this last week. I started a couple of businesses. I unlock cars now. And I'm like, how did you learn that? And she's like, YouTube. And it's going very well. And I don't believe it is, actually, after hearing more about it. I think clients are probably quite frightened. At least I would be. But then they might also say something to you like, I felt really irritable or cranky, but I wasn't tired. I was just really mad at the world because it wasn't moving as fast as I was or as fast as I needed everyone to move. And then they might say something like, and then after a few days, I just crashed and I slept for 2 or 3 days. And then, you just keep asking the questions to get a sense how often you want a bunch of things happening together. If you look at the screener, it does say that it has to be in a symptom. I think this one's in your packet as well. But it has things in there like, I had a lot more energy than usual, or I was more active. So, let's see here, I telephoned friends in the middle of the night. I had more sexual interest than usual. These are all accurate things that are definitely happening. But you want to be super clear when you're using the screener to people that you mean at one time. Like you weren't sleeping and you did all these things. Not like there's sometimes when I feel really sexual, there's sometimes when I call my friends in the middle of the night, there's sometimes when I'm doing more risk taking, because that is like adolescence for a lot of people, you know? Or, as we know, there's like a really prolonged adolescence. If you're at a place like IU or Notre Dame, like your adolescence just keeps going and going and going. And not all those people have bipolar. Like some of them do for sure. Like my college roommate did, but not everybody. So it has to happen together, you know, at a certain time. And sleep problem has to also be occurring together. Okay, so if you find that they have that, don't give them an antidepressant. Call CHAMP to get help or send them to a psychiatrist who can be antidepressant. And then don't forget about substance use disorder when you're doing all this. That's another reason why people come to me and they say, well, yeah, I have bipolar. And then I ask them more about it, and they were diagnosed with this when they were using a lot of stimulants, say Ritalin or Adderall or even methamphetamine. They weren't sleeping, they were doing all this risk taking, but that's not bipolar, that's induced by the substance use. They can co-occur, obviously, because when you're going through a manic episode, it's not uncommon that you're going to use more drugs and do more risk taking, but it can't be the only situation. That's why you want to ask them when you are not using drugs is so important. The thing to remember about substance use disorder is it's often the reason why you have been doing a really good job as a doctor and giving them all the right antidepressants, all the right interventions, but they're not getting better. It's often because they're using substance also to cope, and they don't realize that that's making your medication ineffective. So maybe they're drinking alcohol to sleep at night, or maybe they're using, THC or Delta-9 or something like that to help them with their anxiety, and that's just making your medicine totally ineffective. The reason you want to, figure out that they have an addiction so you can give them services or refer them out, because there are many very highly effective treatments that we can do for people. And again, another area that we're under-treating in our country and the world, really. Of course, you're not surprised. There's a screening tool for this. I am not that into screening tools, but over the years I have become into them because they are so darn handy. This is another one of my personal favorites, just like the EPDS. This is the 5 Ps. And like the Indiana Hospital Association, one of the big groups here in Indiana that deals with hospitals, has gotten very into the 5 Ps. IPQUIC is, into it. I think it's getting rolled out. Like everyone's going to have to do this. You guys maybe already are doing it. This one is super engaging, I think, and it really ratchets things up kind of slowly for people, because a lot of people who are perinatal do not want to report substance use, so they're very afraid of DCS, understandably. And this is like, do your parents use it? Do your peers use it? Does your partner use it? It's like asking about a bunch of other people, kind of easing them into being able to tell you that they use drugs. They may still not tell you, but this kind of eases it in a little bit more, rather than just being like, do you use drugs? As the first thing that you ask them, because they might want to say no to that. And then also it's nice because if you really read through this, which is in your packet as well, it gives you different things to do for the different criteria. And there's more. If you go to the Labor of Love website that's listed, it gives you there's additional papers in there to help figure out what to do. Okay, so we've done a lot of screening, and now what do we do? We consider all the treatment options, support options, and also we don't forget about patient preference. This is a little bit of a busy table, but actually shows up quite well compared to what I thought. It stratifies the risk here between EPDS of 0 to 8, EPDS of 9 to 13, 14 to 18, greater than 19. And why this is important is that this block at the end is the group that you would want to consider an antidepressant for. Because if you've ever looked at any studies on antidepressants, they are no better than placebo for mild depression. They're also not beneficial for people going through a grief reaction or adjustment disorder or breakups or things like that. They're really only effective for people who have major depressive disorder, moderate or severe. So making sure that your patient truly has a diagnosis that can be treated for it is extremely important. it's also important if you're going to prescribe to a pregnant person, because when we talk about risks related to being on, an antidepressant, the risk-benefit ratio is only recommending of the antidepressants for medicines that they can actually treat. For the conditions that the medicines can actually treat. So we consider the risks of treating, the risks and benefits of treating. And as I just said, a diagnosis is essential, correct diagnosis is essential. And you want to consider both the risk of treatment and also the risk of untreated illness. And stopping antidepressants and mood stabilizers when patients become pregnant poses a significant risk of exacerbating the mental illness. And I don't know when you guys have reviewed in the femur reviews whether the deaths that were occurring, those parents, were receiving treatment or not. We don't know. Was it the depression that contributed to it? Might be. This is from a study by Peterson et al. That shows time to last prescription of antidepressants in pregnant women, showing that people are very likely to be stopped on their antidepressants when they became pregnant, either by their own choice or by their doctors. And I can tell you that this past week, I had 2 people come in, referred to me because their doctors had told them to stop all their medicines. One who has severe bipolar and has many, many suicide attempts. Another one not less dramatic, but also totally inappropriate. And the OB who was seeing her said to me, I don't know why they did this. The psychiatrist had told them to stop, not the OB. And he was like, I don't know why they did this. I said, I don't either. Let's just figure out how to restart it. This is showing people who were on meds versus off of meds and whether or not they became depressed. So if you look at the 3rd trimester in particular, look how high it is. Look at that p-value, 0.00008. Being on your antidepressant when you're pregnant is very helpful to not become depressed. So what are some other perinatal prescribing principles? First of all, keep it simple. This is the most important thing. Don't make it hard on yourself. You don't need to stop something that is working. I will talk more specifically, but most of the antidepressants are relatively safe. When you can do monotherapy, that is preferable. So single agent. If the person's never been on something, you can definitely do good old Zoloft or Lexapro. But the main reason to choose those medicines has to do with not a lot of them getting into the breast milk. During pregnancy, pretty much all the antidepressants, even Paxil, are actually relatively similarly safe. So that's why it's so important to pick what works for your patient, which is usually the way you can tell that is they're already on it and they're doing well. And then the other thing is you want to dose to remission. You don't want people to be on the medicine and still depressed. Because when the epidemiologists, out in Mass General, et cetera, have looked at hundreds of thousands of people on antidepressants who've been pregnant, and they've tried to figure out, is it the depression or is it the medication that's the problem? It trends more towards depression being the problem rather than the medication causing things like the miscarriages and the low birth weights. But when they are on the antidepressant and they're still depressed, then you're both exposing them to the medication and to the depression. So don't do that to your patient. If you're going to prescribe it, you need to give them enough for them to get better. And remembering that pregnancy is a catabolic state. So as they go along, that they may be getting more depressed because that's, their hormones are doing that to them. Or the antidepressant's the same dose, but there's less of it is in their blood. And so they're just getting less treatment. This is the same thing basically that I just said. But they're also saying here all the risks of the depression. And so there's no such thing as no exposure. You're either going to be exposed to your depression or you're going to be exposed to your medications. And the research points more towards depression being more damaging than the medications. So I know people might want to know about some specific medications. So here is from McPat for Moms. This is what you would do if your patient comes in on no medication. Please don't ever change your patient to these things if they're on something else that's working. But if your person does not have something that works, these are some really nice, starter options. Remembering that the main reason we're choosing Zoloft over Prozac, for example, is because of the postpartum state and breastfeeding. Prozac is just as good during the pregnancy. Also, other things that can be considered relatively safe that you may have been told that you need to stop. You can keep people even on tricyclic antidepressants. We thought that they weren't safe, and that we do know that there can be some like maternal toxicity, so overdose risk is higher. There may be some neonatal withdrawal, but if your patient does really well on amitriptyline, probably unlikely these days, but let's say your patient does well on that, don't yank them off. If you decide that the risks are not right for that particular person in that particular situation, you still want to taper. But for a lot of them, they might be able to stay on it. So what about bipolar disorder? So you might be thinking like, I don't really want to medicate someone for bipolar disorder. Correct. You probably don't want to. If they have to be started on something, you probably want to send them to me or we'll call Champ and be like, what do I do? But if they're already on it from another doctor, don't stop it. Because here's what happens when people stop it. You see the graph here on the right? The blue is people who were, let me start over. These people here are pregnant and postpartum people who were on lithium. And the graph on the right was when they discontinued people from lithium. The blue line is non-pregnant people that were discontinued on lithium. Some of them got ill. But if you look at the people who discontinued it, the proportion that stayed stable in the postpartum period off of their lithium, it was went down to 0. So we're not trying to do this to people. And you're probably like, oh, but Dr. Arnaudo, haven't you heard about how dangerous lithium is? This is another one showing, this is for any psychiatric medicine, not just lithium. Haven't you heard about all the risks with lithium? Yes, I have, and we're going to talk about that in a minute. But this is just people with bipolar disorder who were either kept on their medications or not kept on their medications, but this is not just lithium, this is any of the medicines. And so rate of relapse for people that were stopped on their medicines versus rate of relapse for people that were not stopped. So yes means they were on their meds, no means they were not on their meds. So 66% of people not on their meds had a bipolar episode. So bipolar episodes are obviously, as we talked before, quite risky because they can lead to things like substance use, psychosis, suicide attempts, car accidents, promiscuity, so sexually transmitted diseases. They can lead to injection drug use. So we really don't want people to have bipolar episodes while they're pregnant. So we don't want to stop their medicines. These are some of the medicines that they might be on. They might be on antipsychotics for their bipolar. They might be on anticonvulsants. And they might be on lithium. A medicine that's not on here is valproic acid or Depakote. You do want to stop that one. That is the one medicine you absolutely should stop if someone is on it. In fact, you shouldn't put someone on it who could become pregnant unless you're going to give them an IUD, an Nexplanon, tie their tubes, or do a hysterectomy. That is the only situation in which you should be giving a person of reproductive age Depakote. Because that's the one thing that as psychiatrists, I can tell you, we even with, not just any psychiatrists, as I said before, they're taking people off. But that's the one non-starter for us. Put them on one of these other ones, though, or have someone put them on one of these other medications. Antipsychotics are, right now, I would say, probably the preferred treatment for bipolar disorder during pregnancy. MGH has a big registry, and I've trained at the Brigham, so I'm doing a lot of MGH advertising today. I don't really know if it should be a competitor. They're together now at Partners, so I guess we're all friends. But MGH does have a registry that I linked up here, so any pregnant person on an antipsychotic can register for this. They do have a dearth of Midwestern moms, so we should be trying pretty hard to get our moms on antipsychotics to register for this. And they've been doing studies on the antipsychotics for more than 20 years, and they have not found, risks such as teratogenicity, congenital malformations to be associated with second-generation antipsychotics. There can be some time-limited withdrawal in the infants, just like with antidepressants, but it's not like a lifelong problem. There's also some instances of low birth weight, preterm birth, small for gestational age, or large for gestational age if they get diabetes. What's really interesting is that's specific to the maternal diagnosis. So if the mom has bipolar, these things are more common, but in perinatal, people who with schizophrenia, these things did not occur in their infants. Just to say that there, again, it may not be so much the medication, it may be something related to the diagnosis. So the take home is, don't stop these medicines abruptly because it leads to greater than 70% increase in illness recurrence. And that is much more risky to the fetus than is the medicines. The other good one is lamotrigine, Lamictal. It's a lot harder to start this one. You have to go a lot slower. It doesn't cover mania, only depression. But the purpose of this slide is to say, if your patient is on this medicine, when they become pregnant, don't stop it. And it's something that could be considered for bipolar. So if your patient says their psychiatrist is considering it, it's a reasonable choice. And it's a reasonable choice in pregnancy. It's a good choice in pregnancy. Lithium, it can also be a reasonable choice, believe it or not. In Scandinavia, they use a ton of lithium during pregnancy. One of the big Scandinavian researchers is now in New York City, trying to teach us all that this is a valid option. In the postpartum period, it's particularly a good idea. It's very good at reversing postpartum psychosis. It can be challenging with breastfeeding, although it's not a non-starter. Like, some good pediatricians will help you work with patients on this, and you can monitor the baby and the adult. I was going to say the human. Babies are human, kind of. But definitely want a psychiatrist on board helping you if you're going to do this. And you don't want to. Most importantly, though, don't stop it abruptly. Okay, I know there's going to be a lot of other talks about resources and referrals, so I am going to focus on CHAMP. This is the program that I'm co-medical director, and we have Carmen and Dylan here with us. They have some folders. Maybe we should pass them out now. Okay, and they're going to pass out our folders. I know you already got some fantastic folders, but we have some folders too. So we are a perinatal access program. We are funded by DMHA, so your state entity is funding us to provide phone consultations to prescribers all across the state. You can be a private practice person, you can be a university-based person, you can be a hospital-based provider, you can be any kind of person who writes a prescription can call CHAMP. Today we're focusing on perinatal mental health, but CHAMP has also a general adult branch, which Dr. Michael Metrick is my co-director. He directs that part, and I direct the perinatal part. We're part of the new millennium, and we have these QR codes as well, and they are in the folder, so you can quickly scan and register with us. By registering, what that means is just that we have your name and information. So tomorrow, when you go see your patient who is on lithium, and you're like, oh, Arnaudo said not to stop it, but I don't really know what else I should be doing here, you can call us and we can help direct, how to proceed. And just to make it clear, not every patient on lithium should stay on lithium. You don't necessarily have to immediately stop it. What do we provide? We are available from 9 a.m. to 5 p.m., Monday through Friday, except university holidays. I don't know what those are always, but like Christmas and New Year. I work on those days, so it doesn't affect my life as much as, Anyways, it's probably similar up here. Let's see here. It's same day phone consultation, so you would call us. And Carmen or Dylan, these lovely folks here, you've already met them. They're real people. They're not artificial intelligence. They will answer, and they'll take your information. They'll say, oh, awesome, you went to the talk in South Bend. You're already registered, which you guys are going to do right now as I talk. And they're going to say, your question's perinatal. All right, let me get some more information. They're going to say, do you want them to call you back right away? Or would you rather, like, at the end of the day? Or do you want them to call you tomorrow maybe? Because, maybe you're quite busy right now. You can do that too. We can call the next day. One of us will get on the phone. All of us are psychiatrists that cover the lines. Most of them are in Indy. I'm the only one, I think, who's in Bloomington. And
we're all have expertise either in whichever line we're all on, in perinatal or in general adult. You'll ask us your question, we'll give you some recommendations. We also type up a small little report about what we recommended, and then Carmen and Dylan will send that to you guys so you have it for your records or to refer back to you. We will ask you for a little bit of demographics and information about your patient. The reason for that, we're fully HIPAA compliant. We use RedCap, which if you're researchers, you've heard of RedCap. It's very secure. We will put that information in there primarily so that if you call us again, or let's say you're part of a practice of physicians or nurse practitioners or midwives, and your patient, we give a recommendation, you try it, but a few weeks later it's just not working and you want to know what to do. When you call back, it might be a different person staffing the line, but that person will have the information from the other time you called, so they'll be able to be more agile at answering your question. So that's why we need the name of your patient or the demographic. Okay, so that's CHAMP. Use us, and that will be great. That will help everyone. And so, what are some of my takeaways that I hope you guys heard? There's things up here, but I guess I'll give my own version of what the takeaways are. Use the screeners, there's a lot of them, but use them intelligently. Like, use them to track and ask additional questions. Don't stop medications. Sometimes you also need to start them, but most importantly, don't stop them if the person's already on them. And if you have additional questions about exactly what to do on a case-by-case basis, call CHAMP, and we will help you. That's it.
Next, thank you so much, Dr. Arnaudo, that was wonderful. Talking about best practices with screening, follow-up, and referrals. A little bit more about what to do when someone screens positive. So our two speakers, I'm going to introduce both of them. Jennifer Carter is an LCSW with Family Psychology of South Bend and E. Blair Warner Memorial Family Medicine, and a Postpartum Support International Support Coordinator for St. Joseph County. She's trained as a medical social worker. Jennifer understands the impact of mental and emotional health on the whole body and uses a biopsychosocial approach to her work. Most of her clinical practice has focused on maternal mental health and perinatal mood disorders, including perinatal depression, anxiety, and traumatic birth experiences. And she's been a member of the Fetal Infant Mortality Review from the very beginning, 7 years ago. And Lisa Kelly is LCSW, MPH, psychotherapist in private practice. Her degree is from Columbia University. Lisa's balanced clinical practice and program development for almost 30 years. She's worked in a variety of settings in her career as a community-based home visitor in New York City, a hospital-based social worker in Baltimore, Maryland, and most recently as a private practice clinician in South Bend. Working with pregnant and postpartum women is Lisa's passion. Since 1993, she's focused her practice on perinatal mood disorders. Lisa received her training for her specialty through Postpartum Support International and Marseille of North America. She co-founded and coordinated the Sinai Hospital Perinatal Depression Outreach Program, a hospital-based screening and outreach program in Baltimore. And since moving to South Bend in 2011, she's been in private practice, specializing in pregnancy, postpartum anxiety, and depression, as well as grief and loss. Lisa is a co-founder and president of Health Awareness of Michiana, which focuses on eliminating the stigma of mental illness and improving access to mental health care in the Michiana community, and she organized the event that's tomorrow, the Maternal Mental Health Symposium. So welcome, Jen and Lisa.
So you've heard a lot about screening tonight. So we're going to talk a little bit more about screening, but I think from a little bit different angle. So I'm Lisa Kelly, and as you heard Sally said, I'm a clinician, but I also have background with setting up a hospital-based screening program in Baltimore, and so I'm going to lean a little bit into that when we're talking about screening practices. And, okay. So, all of our goal, what we're all here for is basically to have healthy moms and babies, and as Dr. Arnaudo said, at least half of the women who suffer from perinatal mood disorders are not diagnosed. So our goal is early identification, proper diagnosis, and effective treatment. Your role as physicians is really important. you are trusted individuals and you have regular contact with women, so that during the pregnancy and postpartum period, you are probably the most trusted professional that they have contact with. So your ability to talk with a woman about what's going on an emotional level is really important from a patient satisfaction point of view, but also as a first point for someone to start thinking about getting help. So when I have referrals in the 20 years I've worked with pregnant postpartum women, I will regularly have women say to me, my doctor told me that I should speak with you, and because she trusts you, I'm going to trust you. And especially for women who have never gone in to see a therapist before, a doctor saying to them, this is somebody who I think you can trust, incredibly important. So I really want to emphasize that as trusted providers, you have a lot of power in terms of being able to talk somebody into getting help. So I don't want to, over amplify that. And you may already know just how much you're trusted. But for what we're talking about as a point of entry into getting help, just over the years, it's just proven over and over again that your voice matters. So we're talking about screening recommendations. Dr. Arnaudo did a great job talking about the different types of screenings. And even though ACOG and other professional organizations are recommending screening, there's still pretty low rates of screenings done prenatally, postpartum. For women with public insurance, it's less than for women with private insurance. And pediatricians are actually pretty good about screening, but even with them, it's less than 50% are screening. And you've heard all about a whole bunch of different screenings. The ones that are probably most regularly utilized are the Edinburgh and the PHQ-9. So we're going to talk about, why you should be screening. And I do want to acknowledge that when we talk about screening with intention and doing it well, I am very well aware that it takes time to do this, and you're working in healthcare systems that really don't promote that. So being able to sit down, explain a screening, review a screening, talk with somebody about their options, your office settings aren't necessarily promoting that kind of time. So you can actually screen badly. So this is a study from 2021, and women were asked about their experience with screening, and the response that these researchers found is that a lot of women found that screening was actually ineffective because the providers didn't explain the purpose or use of the screening tool, didn't tell the patients anything about the results, and failed to provide any follow-up relating to patient depression scores. So when we talk about screening, what we really don't want is for somebody to be given a piece of paper, told fill it out, and then there's no follow-up whatsoever. So we're talking about best practices, and this is what we would suggest. So the screening really needs to be introduced by somebody. And so when I was hospital-based and we set up the hospital-based screening program, we actually gave the nurses a script to use so that they felt comfortable introducing the screening tool. So this is just, you can use whatever introduction you want, but the point is that you have somebody who basically is normalizing why you're doing the screening. So being able to say, just talk about the prevalence of depression, anxiety, and that this is something that they're giving all of your patients, and that the purpose is to see how you're doing and to see what you as their provider can do to help them if they're struggling. Scoring the screening results is important. Dr. Arnaudo referenced doing it with the patient. I think, the point being that we actually want you to screen and do the scoring so that you can talk about it with your patient. And what I would suggest is that every patient actually needs education about the risk of perinatal mood disorders. So whether the score is low, moderate, or high, every patient actually should get the follow-up with the score as well as what the risk is going to be through the pregnancy or postpartum period. And even with folks with moderate scores, I would say they also should be followed up with discussion about the risk and introducing the idea of treatment if things get worse during the pregnancy or postpartum period. And I would encourage screening again at their next appointment. And then with the high scores, I think Dr. Arnaudo did a great job with this in terms of evaluating risk, discussing treatment options, and then rescreening and following for the remainder of the pregnancy. So once you are developing the plan with the patient, we of course want you to make referrals with the patient's consent, and the important piece is to follow up. So I know that a lot of physicians who refer patients to me, I go through the process of making sure that they know that the patient has come in, what our plan for follow-up is, and I know that they also follow up with their patient to ask, how did it go, right? So you met with Lisa, you know, how did the session go? Are you going to continue to follow up with her? So we do, you know, Jen and I, when we were talking about this, we are recommending a team approach, which is the medical office, the community resources, and PSI, that between those three legs of the support system, that we're helping women to basically get better and hopefully get better quicker during the pregnancy or the postpartum period. So I'm going to turn things over to Jen, who's going to talk about support services, but thank you.
Thank you, Lisa. All right, so we've talked a lot of tonight about what we can do to help women and families in our area to get them connected to resources. Dr. Arnaudo talked about, and Lisa did, about this treatment option. So let's take a deep dive into what that's going to look like here in our area. We know that screening alone, as Lisa just mentioned, is not treatment. That's the beginning phase of that. And what I want you to know today, there's a lot of medical providers in the office. There's a lot of support people within our community. We are all responsible for taking our step and making sure that our patients and our loved ones in our community follow through with the resources that we have available. It starts with the education. It's going over the screening. It's going over the symptoms that they may be talking and you may be listening to. And then it needs to be individualized. Not every person is going to fall into a category, and not every person is going to be best for individual therapy. Not every person is best suited for group therapy or even doing virtual therapy. Some people need a hand to be able to take them to a place to be able to get assistance. What I want you to know today is that we do have these resources in our area, and I want you to know about them so we can talk about them and we can refer to them and we can get more people involved and get the help that they need. I know many of you are sitting there thinking we do have a lack of mental health resources in our area. And although we do, when we can work together, we can find help for people that need it. In my world as a social worker, the phrase is start where the client is, and that's what I would encourage you to do. Not to go by an algorithm in front of you. I'm going to give you some resources, and not to hand that to someone and say, here, find something, but let's get familiar with them so we can find a good match for people to make this successful for them. We know that this discussion also, like many of our discussions, have to include empathy, information, and giving practical help that leads women and families to the effective treatment to help them. One of the things I like to teach, a lot of you have been in the room as I've been teaching over the years, let's talk about your answers and let's talk about how we can help you and how we can be a team together. So here we are in our area. Here's what we have available. For our inpatient services, as Dr. Arnaudo discussed, that highest level of care, you have someone in your office, they're answering the highest level on question 10 on Edinburgh or a PHQ-9, and you're needing immediate assistance. We do have that available here. I'm going to talk about some organizations specifically. I am here to talk about community resources. I don't favor one over the other. I want you to know what's available. Epworth, Oaklawn, and Michiana Behavioral Health are our inpatient options, but that's not it. Through Postpartum Support International, we also have access to inpatient perinatal psychiatric programs, some in New York, North Carolina, and California. We also have intensive outpatient programming hospitalization within 2 hours of where we are here. So we have some of these resources to be able to access. Other information as you're getting those PHQ-9s and Edinburghs and other screening tools in front of you, use our helplines. I just had a patient tell me yesterday, Jen, as you're talking to doctors, please tell them what I can do and what other moms in particular can do when it's 3 a.m. and their child is screaming in front of them. I wish I had someone to call. And my heart broke for that person to know that we have these resources. We have helplines where you can leave a message, but we have hotlines, and we have a way for someone to get a hold of another person to be able to help them through 24 hours a day. Psychotherapy, yes, we have those resources here. A good place to be able to start is by encouraging someone to go over the resources that we have. Start with a community health worker. If you don't know what a community health worker is, find someone from the health department after this meeting, and we will tell you about these wonderful angels that walk through our community to help people and connect them to resources. Another good way is by starting with insurance. Having someone, if you have nothing else to say to them, give them information of how they can call the insurance number on the back of their card, whether that is Medicaid or that's private insurance, to find someone and help them through the process of getting on waiting lists. We do have virtual support group. Hi, Sue. Roses, here it is. If you're not familiar with the Roses program, we have virtual support groups through PSI, Postpartum Support International. They run at least about 16 groups at different times throughout the week. But here locally, we have the Beacon Roses program, and then also our Beacon Mother Matters phone program to be able to follow up with moms and dads that may have concerning Edinburghs in the hospital. Currently, we don't have an in-person support group. We're hoping that that will change in the near future, but we have some within our area through MOPS and other church-based groups. We have over 8 home visiting programs that can meet families within their home or in their community to help get them connected to resources. We also have our community health workers and women's care center. We have doula programs, we have birth doulas, we have postpartum doulas. We have the resources to be able to connect people. We have our community health workers and neighbor to neighbor and La Casa de Amistad that may work with our population that are bilingual. And then in addition, giving those good tips for safe practices for sleeping, making sure baby's sleeping in a safe place and that mom and dad are also getting adequate sleep, nutrition, not underestimating the importance of being able to talk about that, and educating on physical exercise. You may be wondering, what do I do now? You have a wonderful QR code of all the community services. Well, I'm not going to say all because we know that we're missing things on this, and we want to hear from you as to what needs to be added here. What do you know about that we can help add and have this available? This is available, whether it's in your exam rooms, whether it's something that your nurses and CNAs, whether it's something that you carry with you throughout the grocery store as you're meeting moms, right, and dads. This is information that we can all use that we have accessible here in our area. In addition to our hotlines and helplines, if you're not familiar, great resource also in the guide, and PSI. I can't help but ask Birdie to talk a little bit about PSI, if she's willing. Postpartum Support International, a fabulous program. As Sally mentioned, I'm one of the support coordinators, so if your mom or dad or someone calls this hotline and asks for assistance, I'm one of the people here locally that talk them through how we can help them. It's such a great organization that we really can use a lot more of.
Sure. So they told me I only have 3 minutes. So if you're a little nervous, like, oh my gosh, is she going to talk another 20? I really wanted to go home, right? That's what you're thinking. So I am Bertie Meyer, and I live in Speedway, Indiana. You know, home of the Indianapolis 500, the greatest spectacle in racing, and getting ready to do that soon. So I was with IU Health for lots of years. And I started and ran a perinatal mood disorder program there, and I now work for Postpartum Support International, and I have volunteered with them since 2000. I was doing a dual life and then suddenly retired and just totally with PSI. If you're going to see me tomorrow, you'll hear me talk for 90 minutes tomorrow on an overview, and of perinatal mood disorders, a little on screening, a tiny bit on breastfeeding, and resources is big. But for those who are not going to be there tomorrow, I do want you to know that through PSI, we have a helpline, which means they call, leave a message, someone calls them back. We have volunteers who check messages and they call them back within 2 hours. So that's not an emergency. They will talk them down, talk and tell them this is common, what you're going through. You're not alone. You're not to blame. And with the proper treatment, you'll be well. Or if they want to talk to someone right away, then they call our hotline, which we are running through HRSA. It's not ours. It belongs to HRSA and government money that got us that. And we applied to be the people who ran it. So we hired like over 40 people. And I kind of feel like I want to play hockey or something right now. I mean, I don't know about you. So anyway, they can call there and get someone 7 days a week, 24/7, 365, and they can get someone answers right away. They'll do the same thing, and what they both do, helpline or hotline, they will find them resources wherever they are. We have volunteer coordinators. You just heard Lisa say that. She's a volunteer coordinator here, which means she knows all the resources here. I know them through the whole state. I know, so you can always ask me, but check in around here with her. And we have volunteer coordinators in every state in the United States and all over the world. So in over 40 countries also. There are virtual support groups, and you got a handout on virtual support groups and in-person support groups in Indiana. Some are missing. The truth is, there's a QR code at the bottom. You can send your clients to an online support group every day of the week, and in so many different for PSI. And they'll say like, well, I'm not a support kind of person. You know what? It is so helpful before they can get in to possibly you for prescribing, for a therapist. They can get into group, learn what a perinatal mood disorder is, what's going on, why they have it, and what resources are. So please send them to our support groups. Warm line, helpline, support groups, closed Facebook page. We have 20,000 people on it. They can talk all the time on there. We have 10 moderators. We have many other resources. Those are the biggies that you can get help. So I'm going to stop at that. Did I forget anything? Oh, thank you. Okay, for those who do not want to take a 2-day training and go on to take advanced training, which you do, if you're prescribers, you want to take advanced psychopharmacology 6-hour CME that we offer, that's amazing. But we offer, for those who don't want to take our full 2-day training, which is good, but if you just say, nah, I don't want to take 2 days, we have a 4.5 CME course that we teach that's called Frontline Provider, just for you. And actually, Camila and I just recorded on April 6th, I think. I do 2.5 hours of overview of perinatal mood disorders, and you can't see her until you watch me. How about that? It's not allowed. You can't get to the next module without me. And then she talks for 2 hours on medications like she did tonight, but longer. And she goes into substance use, and she would mention ADHD there
and in
too.
the middle, there's a little Easter egg. So watch it for a little Easter egg with the two of us.
Oh, yeah. Yeah, it's fun. You'll see we just start chatting and we forget we're being recorded. But it's okay. It's still a great, that's our frontline training. We offer many, many trainings. So please check in if you're wanting to know more in this area. We train people. We have volunteers. And when our clients and patients are calling in to get help, we connect them to our social support, and we get them hooked up with prescribers and therapists who are trained in this field. Because you send them to the wrong person, they're going to mess them up and they're going to misdiagnose them. Okay?
Thank you.
Yes.
Thank you. Thank you.